Thank you, Dr. Sham. I'm talking about the black fibrosis when we are coming to the complications of the different walls. This is overview of the GDDs, tube plate walls, which are presently available, and now Adi is again there. We have got two types of basically materials, polypropylene and the silicones, and two types of mechanism, whether walled and non-walled. In the non-walled, again we have got the ligature options. Typical course, clinical course which a wall follows is that it is initial may have a slightly hypotensive phase. Again, that depends upon the mechanism type of the wall we have chosen. That in the initial beginning of week, then we have got a hypertensive about which Dr. Mayuri has extensively explained, and then we reach to the final desired phase where we have got a stability of the IOP and we are free of complications and looks for a long-term survival for the wall. This is what happens in the dynamics of the aqueous between the tissue and the wall. There is seepage of the aqueous from the AC through the tube over the plate, and here that tissue reaction takes place and the normal encapsulation blab formation takes place. Through this there is a passive diffusion across the tendons. Now the problem starts here, whether these mechanisms go controlled or they go uncontrolled. As we look in the pathophysiology, black fibrosis in general is the major complications which led to the long-term failure of GDD. What happens when aqueous comes in contact with the tissue? There is a release of pro-inflammatory mediators which itself the aqueous contains. Mainly we have found that VEGF-induced tissue growth factor beta is the main mediator for this fibrosis. This led to the fibroblastic proliferations in the episcleral tissue, and then there is a remodeling of the collagen. That led to the fibrodegenerative changes, which is the desired response leading to the normal encapsulation of the plate. But what happens when this process goes slightly uncontrolled? The fibroproliferative changes continue and they overpass these fibrodegenerative changes. So these fibroproliferative changes lead to the scarring in the subconjunctival space and led to the blab fibrosis. So what are the fibrogenetic factors which are involved in the blab fibrosis? The glucomatous aqueous itself is a fluid which has got the inflammatory mediators. Then you have got the glaucoma type, then age of the patients, then the glaucoma drainage device itself being a foreign material to the eye, it itself is a thing which will induce the fibrosis. Now we look at each of the individual factors, how it affects. I've explained that they have got a inflammatory mediators in the aqueous. So when we put the wall, aqueous comes in contact with this and the blab formation starts. So we have got a double sword edge. We require a blab. We also want an encapsulation, but we don't want it to go beyond that. So we require fibrosis, but to in a calculated limited amount. So here this aqueous itself is the originator of the blab fibrosis. That is something unavoidable. Then glaucoma types. If we see the neovascular glaucoma have got a lower success rate. This is the curves have drawn from the some of the meta-analysis. Some of the glaucomas do good. Surprisingly, uveitic also are doing good. Galpantals are somewhere in intermediate, and second to the failed surgery, they are also doing the intermediate. So type of glaucoma can also affect your response of the blab fibrosis, because they have got, like we know the NVG have got the vascular endothelial derived growth factors, so they are more fibrogenic. That's the reason why they have got low success rate over the time. If we see different walls in the different type of glaucoma, we find that the lowest curve is again with the neovascular glaucoma with all the walls. So it means that type of glaucoma is one thing which affects your blab fibrosis. Then the design. The rigid plates have got less to and fro motions with the eye movement, so that means less fibrogenic response. Then the shape of the end plate, we have seen with the Ahmed wall, which has got an oblong end plate, has more movement, antero-posterior movement, so more likely to have fibrogenic response because it induces more chronic inflammations. And then already I talked about the glucomatous fluid coming in contact with, because these all walls has got tendency and affiliation for the protein, and that I discussed with the biomaterials. Both these materials are fibrogenic. because they have a physical liking for the plasma fluid as well as the proteins of the aqueous. So once they come there, contact with that, then the cells also come and adhere to it. Once cells are adhere, cytokines are released, mediators are released, and fibrogenic response starts. In the studies, we have found that polypropylene is more fibrogenic than the silicone oils. Then hypertensive phase, as madam has explained already, leading to an extensive encapsulation and lead to the more aqueous stay there and more fibrogenic response in the later time. Then surgical handling, if we have a rough handling of the tissue or the wall, especially when you're putting suturing the wall, if the surface gets injured with your forceps, then you are likely to have more inflammatory response. That means more fibrogenesis in the later time. So, how to prevent? We have got options of antifibrotics, we have got anti-VEGF, and probably maybe in future anti-inflammatory drugs. Dr. Jani will be talking about more extensively on this, how to prevent this bladder fibrosis in the next presentation. So conclusion, bladder fibrosis is a necessary evil, and it's multifactorial and probably unavoidable because aqueous is finally going to come in contact with the tissue and lead to some fibrosis. Thank you very much.